Hey all, thank you for joining our webinar. We'll be getting started in about 5 minutes. Hi, all. Thank you for joining the second webinar of 2024, Gradient Health Systems webinar. We will get started as people start joining. And before we move on to the session, I'll just go over some housekeeping items. My name is Mariam Khan. I lead communications for Gradient Health Systems. Just to quickly run through this, if you have any questions during the webinar, please use the Q&A feature to ask us. The webinar is being recorded. You will receive a copy of the recording following the web. If for some reason you don't receive the copy, you can access the recording on our website at gradienthealth.org under the training page. And then, as always, if you have any feedback or have any questions, any ideas for upcoming sessions, please email us at customers@gradienthealth.org. I'll now turn it over to our moderator, Dr. Papicho, who will get us started and introduce our panelists as well.
Thank you very much, Mariam, and welcome to our participants. Today we are discussing complications related to spinal anesthesia and drug errors during spinal anesthesia, injecting wrong drugs. Those are the common things nowadays. Looking at how spinal anesthesia have become a mode of choice for delivery during surgery when doing cesarean section. That has led to an increased number of morbidity following anesthesia or mortality. So reasons, that's what are the reasons taking place. What should we do to prevent that from occurring? After discussing spinal anesthesia, we also discuss use of wrong drugs that were not meant for spinal, but maybe because of different reasons, fatigue or failure to read, we inject wrong drugs into the spinal canal, leading to serious complications. To discuss that, we have two great anesthesiologists, Krista Munyani and Lina Njau. So for today's discussion, we have an introduction point. We'll discuss apnea after spinal anesthesia. We'll give some highlights on iSpinal. And among the drugs that have really been used, wrongly injected in the spinal canal, it's tranexamic acid. So we'll have a case discussion, and then we'll end up with a conclusion. So for now, I'll call upon Dr. Krista Munyani to take us through the first part of the presentation.
Good afternoon or good evening, everyone. Thank you so much for the warm introduction. I'm sure you already know my name, and I'm so excited to be taking you through this presentation, and I hope we can all learn something, and I do hope that you will use the chat box because we do need your interaction. So without further ado, let's get into it. So we're going to start off with this scenario. And I would just like you to put yourself in the shoes. I'm sure most of us are anesthesia providers. So just imagine you're in theater, you're on duty, and you've been called to review a patient who happens to be a 36-year-old male who is ASA 1, who is scheduled for a herniorrhaphy because he has a left inguinal hernia. So you review the patient, you do your pre-anesthetic checkup, and the patient has no prior history of seizures or neurological illnesses. They've never been exposed to anesthesia. This is like their first surgery, and they have no drug allergy. So you proceed to the theater, the patient is already on the table, you have good baseline vitals from the monitor, and so far everything is normal. Spinal anesthesia is administered to the patient in a sitting position at the level of L3, L4, and you're using a 27 gauge atraumatic spinal needle. However, a few minutes later, your patient seems to be apneic, so they're not breathing at all. And then from that, they begin to develop generalized tonic-clonic seizures with loss of consciousness. So I would just like you to think, like, what could be happening to this patient? What could be wrong with them? Or what's going on in your mind? What's your diagnosis right now? And please interact with us in the chat box. We just want to know from you, what do you think could be the cause of how the patient is presenting now? So you've given your spinal, your patient is not breathing currently, they're convulsing, obviously with the loss of consciousness. What could be the problem right now? All right. So I think, okay, we have a few comments coming in there. Thank you for your comments. But we still encourage everyone to participate, please. Most people are saying it's a total spinal, but yeah, I think as we proceed, it will become more clear to everyone. So next slide, please. So what are the possible causes? So the first possible cause could be next, please. So sleep apnea. So this might not be so common for most of us. However, studies have shown that patients who are prone to having sleep apnea usually during the nighttime when they're asleep at home are more prone to having sleep apnea after being given spinal anesthesia. And this usually occurs 30 minutes after the spinal anesthesia has been administered, and your patient will basically present with apnea. And of course, if they're apneic, they're going to go into hypoxia. So that would then obviously lead to you noticing that, yo, my patient has stopped breathing, they're becoming hypoxic, and obviously you would need to follow up through with management of this patient's hypoxia. So it's very important for us when we go to review our patients, we ask them, do you have a history of sleep apnea? Do you often feel like you can't breathe when you're sleeping and stuff? Because that could be an indication of possibly the patient having sleep apnea during spinal anesthesia. However, sleep apnea will not be associated with convulsions. Then the next option could be hypoperfusion. Usually when our patients get hypoperfusion after being given spinal anesthesia, it's because we have failed to preload our patients and they've gone into a state of hypovolemia due to the reduced systemic vascular resistance that our spinal anesthesia will have that effect on the patient. So maybe this patient could have had some sort of hyperperfusion leading to hypovolemia. However, that would not have manifested with convulsions or a loss of consciousness per se. Next, please. So in the event that your patient is hypoxic, we have a management scheme here. And basically, you know, if your patient is hypoxic, it's an emergency. The first thing would ideally be call for help, then go through your ABCDEs. So your A being your airway, try to open up the airway. Is it patent? You know, check the position of your patient. If they're intubated, check that. If they have an LMA in place, is it really still in the right place? Check if your patient is breathing. Is it adequate depth, adequate rate? Check your end-tidal carbon dioxide. Also, auscultation really helps a lot. Circulation, you have good monitors. I assume everyone has good monitors. You can check your pulse or do it physically by touching the patient, checking for probably a main pulse. How's their blood pressure? How is their ECG? So it's always good to go through this. And remember, your patient being hypoxic and it being unexplained, it's always good to deem it as an emergency and ask for help while you try to solve the issue. Next slide, please. So what are the possible causes of this scenario? So we've already spoken about sleep apnea, and we've already discussed about hypoperfusion. So just let us know, like, if you do think that this could be the options. However, I think we have more options available. Next, please. So a lot of people had already commented in the chat box, and thank you for that. Most people had said total spinal anesthesia. So given the patient, how the patient presented, and also with the loss of consciousness, yes, I think you're probably on the right track. A total spinal anesthesia is a possible diagnosis for our current patient in the scenario. And another option could be, next, please. So the intrathecal tranexamic injection. And I did see a few comments there in the chat box about some sort of drug injected, but that will be addressed later on. So next slide, please. So when we're talking about a total spinal, I'd like us first to define like a high spinal before we get to a total spine. So a high spinal can be defined as the spread of local anesthetic block affecting spinal nerves above the level of T4. So remember, usually you're supposed to have a general marker. So the level of T4 is about the level of the nipple. So you're supposed to know, like, around about that. That's where I aim. My spinal anesthesia should not ascend above that level. However, if it does ascend above T4, then we say it's a high spinal. If it continues to ascend, we may go into what we call a total spinal, where we have an intracranial spread of your local anesthetic, which results in a loss of consciousness. Something similar to the scenario we are discussing. Next slide, please. So the reported incidence of high regional blocks varies between 1 to 5,000, about 5,000 patients. However, even though the incidence of high spinals is quite high, it still is, the incidence of a failed intubation is much lower. So the risk of you getting a failed intubation is lower than the risk of you actually getting high spinal. And okay, thank you. So the important part here is for you to recognize what is happening. Early recognition can save your patient's life. Usually we have a rule in theater that once you have administered your spinal anesthesia, do not turn your back on your patient. If you're the one who's given it, allow the rest of your team members to carry on with other duties, but continuously check on your patient, observe them, talk to them. Talking is one of the ways to be able to assess your patient in an easy way, because some of the symptoms the patient will present with when they have a high spinal is they'll have weakness or tingling of arms. So the patient can begin to tell you things like, oh, I feel bad, I'm feeling weak. They can tell you, I feel nauseated, I feel like I'm about to vomit, I'm feeling lightheaded. And of course, on your monitor, you begin to see things like severe hypotension accompanied with bradycardia. So once you talk to your patient, you're constantly observing them, you get to see these changes in their voice, and also, are they able to respond, to speak to you in full sentences? Are they able to respond to what you're saying? Asking them to hold your hand is also a good assessment, or asking them to high five you in an attempt to see if they can still raise their hand is also good. And being able to test your dermatomes. So when you talk about dermatomes, you mean like an area of skin that is innervated by a single nerve root. So you're basically aiming for that to be, usually we have an aim of about T8 or T6. We don't want it to go to T4, otherwise it's approaching a high spinal. Next slide, please. So with early recognition, like I had already said, don't turn your back on your patient, just continuously check for the dermatomes to realize where your spinal has ascended up to. Your monitor is also a good guide and a helping aid because your ECG is there. You can look at your heart rate. Your pulse oximetry also gives you the saturation. And a high regional block often happens very early and it can be very fast. So you always need to be alert and attentive so that you don't miss anything. Next slide, please. So once you recognize, you're able to recognize that something is wrong with the patient, that this block has ascended beyond where I wanted it to go, it's always good to initiate the appropriate management because here we're talking more about our obstetric patients. So it's always good. Remember, the best way to resuscitate the fetus is by resuscitating the mother, and be aware that physiological changes that happen to the mom during this time, such as hypertension or hypoxia, will affect the fetus. So it's always good to have a quick recognition that this is a high spinal. Yes, next slide, please. So in terms of respiratory compromise, so don't forget that in managing an emergency situation, the first thing would be to do, I think we've already talked about it, call for help. After calling for help, just have it in your mind that I have to go through my ABCs. The first being your airway. Now, airway would be associated with the respiratory compromise. So you're there assessing your patient. Are they breathing? The depth of their breaths? Are they adequate? If they've completely stopped breathing, you might consider a tracheal intubation. However, if they're still breathing and they feel like they need support, you can opt to give a high flow oxygen, or you could probably opt to give try to ample bag them in an effort to support their breathing. Also, if they're not completely breathing, you've opted for a tracheal intubation. Don't forget, it must be a rapid sequence induction. Right? So that definitely means you need help, you need assistance, and you should have prepared your drugs beforehand, your induction drugs. Don't forget cricoid pressure to try to avoid the patient vomiting and then leading to aspiration. And then also, don't try to just go into intubation if your patient is semi-conscious or they're still awake, because that would mean you're traumatizing them and you're exposing them to an awake intubation unless they're unconscious. Next slide, please. So in terms of an emergency intubation, it's very likely that you might be nervous. You're not anticipating that your spinal anesthesia would result in a complication. So it might end up being a failed intubation. You might encounter some difficulties like a difficult airway. It's okay. It doesn't have to be the end for that patient. What you need to focus on is ventilating the patient. Remember, once you've given your induction drugs, you probably paralyze them. That means you have to support that patient by manually ventilating them. So I'm talking about a face mask. A good face mask with an ambu bag can help a patient. Remember, you're trying to ventilate them. The goal here is to ventilate them, whether you succeed in the intubation or whether you're going to manually ventilate them. Next slide, please. So once you've made sure your airway is secured, you can then move on to, and once your airway is secured, you've taken care of breathing, you move on to C according to your ABCs. So with C, you want to make sure that you don't want the block to ascend any further. So you do what we call a reverse Trendelenburg position. In simple words, head up, legs down. You're using gravity to try to prevent the local anesthetic from ascending even further. You're going to give your crystalloids, assuming your patient should have an IV line that's already there. You can consider vasopressors if your patient has developed a severe hypotension as well. Don't forget that if you get a severe hypotension, it will directly affect the fetus circulation as well. Don't forget to place your patient in the left lateral position, or more like a left tilt, to avoid compression, to avoid aortic curve or compression. That's another way to give sure resuscitation. Next slide, please. So in addition to you giving your IV fluids for the crystalloids, you can also opt to give your vasopressors in addition to the crystalloids in the form of an infusion. I'm sure we have several vasopressors we use in our centers. A couple of popular ones are drugs like ephedrine, phenylephrine, adrenaline, that really help us to resuscitate the patient and get the blood pressure back to a standard. So don't forget that if you fail to resuscitate the patient and you might end up in a cardiac arrest, it calls for advanced life support. Also, yeah. Okay, so with the management principle, once again, I want to emphasize early recognition. It's better for you to call for help, and when the person comes say, I think this is a high spinal, and for it not to be a high spinal, then for you to really and truly have a high spinal and not call for help and try to manage the patient alone. So I think the call for help after you've recognized the signs and symptoms should be the first. Call for help from your anesthetic team, the surgical team, the scrub nurses, anyone who's around should be on board to help. Once again, your ABCs. Your ABCs following that algorithm can never let you down in order for you to save a life. I'm sure you can see here the management of a high regional block in obstetrics. All right, next slide, please. So here we have a table of our vasopressors, common ones, like I already said, ephedrine, phenylephrine, epinephrine, norepinephrine. The good thing about these drugs is that we discussed them in detail in the last presentation we had for the last month. But here are just some how to dilute it. You can refer back to this table, the concentration that you get and the boluses that you can give to your patient. So these are always good to have emergency drugs on standby in your theater, in a place where you and your assistant know where they stay. They should clearly be labeled and ready to be used at any time. Next slide, please. So, of course, complications can occur. We might get a high spine that might even go into a total spine. But it's good for us to focus on how to deal with that, how to manage that emergency situation. But what I would like to draw your focus on more is steps to take to even prevent your patient from having a high spinal. And this all comes from how prepared you are before the procedure. So I'm sure we are familiar with contraindications for us giving our spinal anesthesia. I'm sure we refer to them daily and we are familiar with them. A few are if your patient refuses, your patient has the right to choose the anesthetic technique they want to go with. Of course, another contraindication is if you are untrained or you are uncertain about what you are doing, please do not proceed. And make sure that the patient is not infected in the site you're going to be working on. And platelet function, usually we say platelets should be above 80, in some centers 75 and above if your patient has thrombocytopenia. So always take your time to prepare. I know some cases are emergency, especially in obstetrics. The life of the fetus is sometimes in our hands and time is not on our side. But you should always obtain consent. Make sure you pass through your pre-anesthetic checklist that involves all the teams, surgical team, anesthesia team, as well as the spub nurses, so everyone is on board for what needs to be done. Make sure you have your standard monitors there, as well as your drugs, not just your spinal anesthetic drugs, emergency drugs, as well as possible induction drugs. Preload is also important. Don't forget to skip that point. And technique, I'm sure we all know it's an aseptic technique. Don't try to save time by not following the aseptic technique rules, because later on that could cost your patient in the long run. Make sure you use your bupivacaine. Make sure that it's preservative-free, local anesthetic that you use, and make sure to cross-check all the labels on the bottles that you're using. Next slide, please. Prevention strategies. So you should consider the level of the required, consider the level that's required for you to get an adequate analgesia or adequate block. In some cases, you don't need your spinal to go all the way to T6. A T10 or a T8 is fine, and that's okay. You can adjust that according to how you lay your patient on the bed. Also, you should consider the volume. Not every patient is to be given the same volume. Obstetric patients, you have to consider their physiological changes, the increased lumbar lordosis that they have, also a full belly, consider the patient's height, their age, their weight. So we have to tailor anesthetic drugs according to our patients. We have to individualize our management, especially when it comes to us giving our local anesthetic. And also your technique, you should make sure you have a good needle, make sure that you use the use of barbotage and the speed of injection. So when it comes to epidural anesthesia, you should try to use low concentrations, especially for labor analgesia. You should always be available to assess your block. Make sure that you're aspirating 2 ml syringe to check that the catheter is not in the cerebral spinal fluid. And you should give a test dose. It's always good to give a test dose to see how the patient reacts, if they have any adverse reacts, and to check that you're in the right space. Yes, these are all points in order for you to have a more safer local block. Next slide, please. So the clinical effects, if you want to know, like, if my spinal anesthesia goes up above T4 and it goes all the way up to between T1 and T4, you're probably going to end up with the cardiac sympathetic fibers being blocked. What will this result in? In a bradycardia and severe hypotension, because you've now caused that, if you've now reduced the systemic vascular resistance as a result of the blockage of the sympathetic preganglionic fibers when you go between T1 and T4. If your block continues to ascend all the way between C6 and C8, it's going to affect the patient's hands and arms. That means they won't be able to raise them. They won't be able to hold a grip. If you ask them to squeeze your hand, they won't be able to. They'll feel tingling and a weakness. If it continues to ascend, it might actually affect their respiratory muscles as well. Getting to C3 and C5, affecting the diaphragm and shoulders. So that is like the respiration of your patient will be compromised and will require possibly intubation and mechanical ventilation and manual ventilation on your part. And if it goes to intracranial spread, I'm sure from our scenario, we know that there will be a loss of consciousness and slurred speech, and your patient will be unresponsive. So I think that brings me to the end of my part. Thank you.
Thank you very much, Dr. Krista, for this nice presentation on eye and total spinal. Now we are going to move to the next part, second part of the topic. Dr. Lina, she's going to discuss with us the advertent injection of tranexamic acid into the spinal canal. Dr. Lina, you are welcome.
Okay, thank you. I'm Dr. Lina from KSMC. Good evening, everyone. So let me pass you through this, another catastrophic complication of spinal anesthesia. So what do you think are the risk factors for drug errors in anesthesia? You can just try to think and comment in a chat box so we can just see different responses from different people. So just comment on the risk factors that can lead to drug errors during our practice in anesthesia. There's a comment that says fatigue, lack of counter checking, improper labeling, burnout syndrome, similar appearance of ampules, unlabeled syringe, poor vision, and poor drug preparation, improper dilution of syringe. Okay, thank you. So let's continue, and then we see as we discuss. So medication error has been, this is a crucial agent leading to mobility and mortality in our countries, and it has been showing the incidence of perioperative drug error ranged from 1:100 in anesthesia providers and 1:20 for drug administration. So the most common known factors associated with this complication can be due to similar appearance of ampules, as some commented on that, incorrect labeling, poor double checking system, even location of ampule, and sometimes negligence of poor communication and exhaustion. Next, please. So as we can see from this slide, we see different drugs that look similar. As you can see, there is furosemide and tranexamic acid. Also, there is ketamine and succinylcholine. You can see atropine and the hyoscine look the same. Or vitamin K and promethazine look the same. And this is the one of the things or risk factors that is associated with this complication. Next, please. So tranexamic acid versus heavy bupivacaine, and this is the leading medication that's caused this effect compared to other drug during cesarean section, because study has been showing a lot of incidents and cases reported from intrathecal injection of tranexamic acid for bupivacaine. Next, please. So we know tranexamic acid has been reported to be the most common drug implicated in drug errors for spinal anesthesia, and the incidence is high in cesarean section, and it is a global complication and has been addressed also by WHO. WHO reported that there are a lot of cases that has been happened due to intrathecal injection of tranexamic acid for obstetric spinal anesthesia used for cesarean delivery. Next, please. So as we can also see, different cases in different journals from different countries has been addressed this complication, and also it has been also reported, there are some cases reported for accidental injection of digoxin. So there are some links will be sent in our chats so as we can just pass through these articles. Next, please. So as we know, we use tranexamic acid in our surgeries to minimize to minimize bleeding, and this is the antifibrinolytic agent that's we know it's used to inhibit activation of plasminogen to plasmin, and also it inhibits the disintegration of fibrin that stabilize the clots, and this helps us to minimize bleeding or hemorrhage during surgeries. But accidental intrathecal injection of tranexamic may lead to serious side effects that can be CNS manifestation like myoclonus seizures and cardiovascular manifestation like arrhythmias, and at the end can lead to cardiac arrest. Next, please. So intrathecal tranexamic acid is a potent neurotoxin and can produce neurological consequences like seizures and myoclonic, as I said before, and that it has more than 50% mortality rate. And a lot of studies have been commented on increase in incidence even in our country. There's a study shows done in South Africa and showed that there is a raised possibility of this problem to be more prevalent than suggested by published cases reports. And more reports has been commented on this increase of incidence in this complication. Next, please. So the mechanism of action for this manifestation is not well known. However, it said that it causes suppression of inhibitory GABA A receptor in cerebral cortex. Or some studies commented that can be the cause due to direct cerebral ischemia as a result from reduced cerebral blood flow. And this blockage of GABA A receptors by tranexamic can lead to lower threshold for neuronal depolarization and hence enhance neurotoxicity, leading to seizures and myoclonus. So the effect is suppression of GABA A receptors. This is the inhibitory neurotransmitter receptor. Next, please. So how do we manage the patients with this incidence? Remember our ABC, that you have to make sure your airway is patent, because remember your patient will be presenting with convulsion. So make sure your airway is patent, make sure your patient is breathing. If not, you have to assist with breathing, and also the patient will present with hemodynamical instability. So you have to make sure you assess your pulse, you check your rhythm at ECG, blood pressure, and then you intervene. And also for anticonvulsants, it's a lot of studies has recommended benzodiazepine, like diazepam, and thiopentol has been shown to be effectively working for seizures. And also the protective brain strategies that can be used to prevent more convulsion and ischemic events during this complication. So there are use of mannitol, Lasix, and minimize fluid. And also remember your patient will be presenting with arrhythmias, and the commonest arrhythmia has been reported as ventricular fibrillation. So you provide effective antiarrhythmia, and also another supportive management has been reported to be CSF lavage that will help in removing and diluting the injected drug and limit neuronal complications. But it has been reported with some journals that this CSF lavage can be performed after 3 hours of presentation. So the complication, as I said, your patients can be having refractory seizures, and also mortality is more than 50%. Next, please. So what should be done to prevent this catastrophic complication? What do you think can be done to prevent this catastrophic complication? As we have seen the risk factors and also presentation, because this is a fatal complication and has more than 50% mortality rate. So you're welcome. You can just comment on the chat box and we can just see. Okay, someone has commented vigilancy. Yes, we have to be careful. Enhanced counter-checking system. Proper housekeeping, careful reading drugs. Well rested, yes, we need to rest between cases. Correct drug storage. Pre-check of all anesthetic drug and store them. Okay, thank you. Next slide, please. Okay, thank you. So the preventive measures, as you have commented, is we have just to be very careful. We have just to correct labeling of our syringe, double checking system, drug partition. We need to label them and divide them in order and keep them in a place that can prevent at least minimal mixing of the drugs. Thank you. Next slide, please. So there is guideline for prevention of incorrect intrathecal injection of medication that has been adopted in our country, Tanzania, and we have seen it emphasized in a lot of things, and the common one is double checking mechanism, that you have just to check the proposed drug that has to be injected with your assistant and read it loudly. And also the leftover drugs has to be discarded if they are no longer used. Next, please.
Thank you very much, Dr. Lina, for this wonderful presentation. This is the reference that was used for this webinar. As it was announced earlier on, you'll find this webinar recorded on the Guardian website. Even the previous webinars are all available for personal use at any time. We are checking now in the Q&A as we are preparing for your question. I managed to see among the participants, there's one of the senior anesthetists I recognize there. I'll ask him to make 1 or 2 words as a comment on during his practice, what has happened in relation to this topic of today's. How can we avoid this in actual practice? What should we do so that it's not happening to us? I saw Mr. Kajila, I hope he's still around. You can mute yourself and make some few comments as we are waiting for question on the Q&A section.
Hello. Good afternoon, everyone.
Oh, can you speak up, Mr. Kazila?
Good afternoon, everyone.
Good afternoon, thank you. You can go ahead.
Yeah, thank you very much, Dr. Cristiano, Dr. Lina, Dr. Ntambe, for this wonderful presentation. I think we need to avoid this in order to reduce on the morbidity and the mortality. How? 1, we need to work as a team. 2, we make it a habit that every day the anesthetist has to be available on time. Even when you are called, even when there's an emergency, they make sure that you're always there before the emergency found you. That is by being on time, and make sure that you go through your drug stocks, identify what is there and store them accordingly to avoid similar mistakes. And they make use of your assistant. As you give the drugs, please counter check. If it is bupivacaine, let your colleague also confirm it's bupivacaine. If it is tranexamic acid, where they want to request you to give it as a prevention of PPH, counter check also with your assistant, so that you don't give bupivacaine, as since the drugs look similar in the management of PPH. So really, it has been a wonderful presentation. I hope we're going to see some improvement on that. It's interesting to hear that this thing of drug errors administration is actually global. It has been identified at the global level. Please, I hope we're going to make some progress. Thank you so much.
Thank you very much, Mr. Kazila, for that wonderful comment. We appreciate your presence in this webinar, and we hope you always be there when we announce in the future. We have one question in the Q&A from, okay, you want to be anonymous. What is CSF lavage and how do you do it? If even that two are trying to manage administration of a hormone intrathecally. I think he meant to say barbotage, not lavage. Dr. Christoph, can you get this question?
Thank you. I think he's referring to the lavage for the as part of the management for the intrathecal, the accidental intrathecal injection, because it was mentioned as one of the steps for the management.
Okay. Dr. Sipuka, do you want to make some comment on it?
Yeah, maybe I can make very superficial comment because it's not something that personally I've done, but I've come across it in the literature. And from my personal reading, it didn't sound like, something that you can easily do in most of our settings. So this is actually one of the treatment options to sort of reduce the amount of toxic drug within CSF. In this case, if it's tranexamic acid, it's similar to the gastric lavage, where we want to reduce the amount of poisonous substance ingested by sort of washing the gastrointestinal tract. It's the same concept and principle actually, but for CSF lavage, this is where they would insert two catheters, one above the level of injection, then the other one below. For example, one can be inserted at maybe in the T segment, then another one in the lumbar or sacral segments, and then you get saline and wash out the sort of the toxic CSF within the space. So by doing that, you are just sort of trying to reduce the amount of circulating toxic substance in the CSF. It really sounds like an academic exercise because it's not something that you can easily do. First of all, you need catheters, you need a lot of assistance, and you need to monitor the patient for complications. I need to know how much saline or Ringer's lactate you are going to use for washing out the CSF. So it's really one of those things that can be done to reduce the amount of toxin or chemical within CSF. Personally, I have no experience, but it's something that you find in literature following an accidental injection of intrathecal injection of a wrong drug. Thank you, the chair.
Thank you, Dr. Spuka. Just one more question to you. In the literature, what was the outcome of the cases where they did it?
Yeah, like one of the case studies, the outcome really was okay, but again, the issue is they attributed it maybe to the fact that they had done adequate supportive treatment such that, you know, the tranexamic acid had to be metabolized, you know, physiologically, and it cleared eventually. So they really couldn't tell whether it's, you know, actually the CSF lavage that was effective, or it was just supportive care and also allowing the drug to metabolize and they get excreted from the system. Because there's been also other cases, case studies where there was no CSF lavage which was done, but the patient eventually recovered from injection of the toxic substance. And so it's really difficult to tell whether it's of benefit or you go straight away with just conservative treatment and do your ABCs, ventilate the patient, and manage whatever complications that you are seeing. Yeah, so it's really something that is neither here nor there. But I think at the end of the day, the chair, the most important thing is to do your ABC, D very effectively, because those are life-saving interventions before you actually think about those extraordinary things like CSF lavage. So your ABC, I think that's very, very important, and that's what's likely to save the life of the patient. Thank you.
Thank you very much. And I don't want to also add early recognition and to accept that you've committed an error by giving a wrong drug than trying to hide, and then maybe they can do one or two things in this manner to save the patient. Thank you. There's another question on Q&A. Dr. Sweetbet, can you take it up for the first scenario? How does our management differ from that of an adult to that of a neonate? Yes, Dr. Sweetbet, there's a question. We have two questions in the Q&A. Can you pick up the first one, please?
So how does the management differ? So management of the, what does it mean? Management of the apnea or management of the eye spine?
Maybe you can give
whoever can clarify. Because if he is asking about the apnea, yes, there are cases, actually there are cases on the internet. They were discussing neonatal and neonatal spine. Actually, they were attributing it to the spinal anesthesia, but the review showed it's not spinal anesthesia per se. So I think it's just to clarify what exactly the management is asking. But the ABCDE is the same. So I'm going to make a comment because I don't know exactly what is the problem. But the first scenario, how does our management differ from an adult? So what is looking at? The ABCDE is the same for everyone. It's the kiddies and the adults. So I don't know if he's talking about the apnea or he's talking about the eye spine or the spine. Someone is there. Can he come and clarify? But if he's asking about the apnea, yes. They are seriously discussing apnea for neonatal spinal anesthesia. Actually, they eventually feel that it's not caused by spine.
Okay, thank you very much, Dr. Sweetbet. And then there's another question still. In the second scenario, what do you mean by activation of inhibitory GABA-A? At the level of GABA-A increasing or reducing, leading to the seizures?
Okay, thank you. I would like to respond to that patient. What do you think What do I mean by activation of inhibitor GABA? What I said is it doesn't cause the activation, it causes suppression of the GABA, and the GABA receptor will be reduced, so the excitability effect will take over. That's why your patient will be presenting with seizures and myoclonus. Thank you.
Are there long-term effects of tranexamic acid intrathecal injection? I don't know if you get it better. Is our colleague asking, assuming that somebody survives, what will be the effects of clinical features that patient is going to move away with?
Okay, thank you. A lot of studies have reported the long-term complication will be refractory seizures. That is the common long-term complication that patients will be presenting. However, some studies that have shown after patient has been managed with supportive management and recovered and survived it, post-incidence on EEG and MRI of brain were normal.
Okay.
So when the patient has recovered completely, there is less neurological defect.
Wow, wonderful. Thank you very much. I think that was the last question that we have. Please, go ahead.
And maybe I can add something on that. So, take the injection. Actually, the clinical presentation in the DFIR, there are those ones, actually, those ones who end up with the conversions and actually manage well with only the diazepam. There are those who get the severe one, which actually there is one case where they even end up giving, I think, all the way to Serpento. And it's some, they even use the inhalation agent. There's a case where they even went on putting someone on inhalation agent for 24 hours. And some, as they say, there are some more, they goes all the way to refractory sugar. But there are those who end up with some kind of neurological deficiency, and there are some who recover fully. And of course, there are some who end up with they die. Yeah. So actually, I want to emphasize here that I think once the most important thing is early recognition that I've done something and I have to deal with it. And they're also, again, looking at the CSF lavage. The one case, of course, as Indaba said, they didn't do it because to them, they were like, the patient come to us 3 hours later, and we thought it won't be helpful. So there are so many cases who have survived without even doing the lavage. So I think the most important thing is supportive. And remember, we know, at least we don't know the mechanism, but we know you will end up with the CNS manifestations, or you have to make sure you control seizures. We know you end up with the arrhythm. There are some cases where they have given amiodarone just to prevent arrhythmias. But there are some, they just wait until they have issue, then they manage it. So I think the most important thing is make sure you take care of the ABCDs, and the most important one, the cardiovascular and ventilation. Make sure they are not hypoxic, and also deal with the CNS manifestations. I think doing all of this at a stage, I think you may end up with a good outcome. I think that's my addition. Thank you. Back to you.
Thank you very much. We have one last comment, which seems to be a question to me, maybe addressed to Dr. Kristen. Dr. Chris, the question is like, we want to talk of preload, and then sometimes it delays surgery for it to start. How much fluid do you recommend to give for preload? That's the question.
Okay, so with the studies, they've shown that for preload, we aim to give between 500 mils to 1,000 mils of a crystalloid solution.
Okay.
But we should also be aware in our patients who have preeclampsia to try to minimize our fluids because they tend to be edematous already, presenting with lower limb edema, and they also tend to present with kidney failure. So that is something to note for preeclamptic patients.
Thank you very much for that clear answer. I guess we've exhausted all the questions that we had in the chat box and the Q&A. For now is to say thank you very much to our panelists and to our presenters, mostly to our participants. I'll hand over back to Maggie Magdalena.
Hello, thank you so much for your participation. Thank you so much, Dr. Lina and Dr. Christie. Mine is to just thank you and urge you to watch out for more webinars and also to invite you to go to our website, Gradient Health Systems. There you'll find the machines that we work with. They also have a curriculum. And for those of us who have our machines and are finding any challenges, please feel free to reach out to us, because we'll also be having webinars on the use of our machines in the different scenarios. And yeah, so watch out for more webinars. And in case you're interested, please reach out to us in case you want to also join for the webinars that we'll be working with our machines in case you don't have access to our machines. Thank you, and please share your feedback on customer@gradienthealth.org.